Yes, yes.
Before our meeting at the end of next month, where we have allocated about 4 hours to cover the final detail budget for the district for FY 2017. Today, I just want to take 5 or 10 minutes to go over some major assumptions that will drive these volumes, some of our expense assumptions. These are all preliminary. We are still working on volumes as well. So this is just to kind of let you know we're not planning any major change for 2017, and I just wanted to give you a quick look at what we're thinking. So this has been placed on your portal if you want to follow along under the CFO report, or you can follow along on the board. Revenues for the district are comprised mainly of three sources. And this graph is from last year, but we get about 40% from patient revenue. So when a patient comes and stays at the hospital or comes into an outpatient clinic, we bill for those services. It might come from a commercial plan, like Medicare, Medicaid, Blue Cross, or United. And we also collect from the patients themselves. We also receive ad valorem or property tax revenue support from the county. That comprises about 35%. And then there is supplemental state and federal payments that you guys are all aware of that are about a quarter of that, which is DISH, UC, and DISRIP payments. So when we start to look at those revenues, especially when it comes to patient revenue, it's the largest component of cash income. Like we talked about in May, volumes are what drives most of that revenue. Again, we're not projecting any major significant changes to our volumes, and we'll go through a couple of graphs here in the next few slides. We do plan to do a charge increase. We do that every year. This helps us cover some of the inflationary impacts that we expect. Drugs go up every year. We give merit increases to our staff. And these are allowed in our commercial contracts. So this is an annual increase that we do each year. We also are trying to predict what those new managed care contracts that we've brought on this year, as well as any changes to those rates for existing contracts that we've done this year, will have impacts to the bottom line. And then any revenue cycle improvements. What are we going to do internally? How is that going to change the income statement for 17? Then things that are probably the biggest unknown to us are those legislative changes. What is going to happen with the uncompensated care and the DISRIP? A lot of you are kept abreast of what's happening for DY6 for DISRIP. We think that's going to continue for another year, but we are visiting and trying to plan for that right now for budget 17. Again, I'll bring you the details back in the next month to let you know what we've settled on. But again, we expect that to look very consistent with the DISRIP year 5, which was this fiscal year. And of course, the tax revenue comprises a very large part of our income as well. So when you start to look at our inpatient statistics, we really again are projecting pretty much a flat compared to the current year. Again, the stats you're looking at right now are excluding our inpatient psych days. And we are going to look at psych different
It's all right.
apologize.
You're fine.
Um, so admissions and patient days typically trend very closely together, so that's what those two are showing. Our key outpatient stats, these are the same stats that we go over each month when we look at financial statements. Urgent care visits, we plan to keep flat as well. ED visits are trending up. We're showing currently about a 2.7% increase there. Our community health clinic visits, we're showing about a 1.8% increase currently. We do have a few new providers that we're planning to bring on there. And the total outpatient visits include a conglomerate of different counts, including the first three bar charts you see there. So about a 2% overall increase. This page shows specific to psych service line specifically alone. Patient days, you see a 10% increase there. Again, if you recall, earlier in this calendar year, we were able to expand our inpatient psych beds through an off-campus facility expansion of about 32 beds. So we have a full year impact of being able to see more admitted patients. And if you combine that FY16 and FY17 increase, you see about a 30% increase in patient days, and that was the expansion of about 30% more beds. We see in our psych ED a slight decrease. That is a complement to be able to, in our outpatient partial day, we have been able to expand that. We feel like because we're able to accommodate patients on a partial outpatient, which is more of a daycare program, a very intensive treatment program, that we'll be able to slightly decrease readmissions through our and our clinic visits, we have been able to expand 3 providers in different locations. So our clinic visits, we expect to go up by a little over 20%. For surgeries, this year we expanded our OR by 1. So we have a full year impact of more surgeries coming. So inpatient goes up by about 2.5%. Outpatient, we expect to go up by about 5%. Overall surgeries up by just over 4. So volume again is the biggest driver for our patient revenue. And some of our inflationary assumptions for our expenses. Salaries is the biggest expense. If you look at our income statement, we are projecting about a 3% merit for our staff across the board. And we will be budgeting for a pool for any kind of market adjustments that are required for staff salary adjustments within Tarrant County. Pharmaceuticals, over the last 8 to 10 years, have ranged anywhere from a 6 to a 10% inflation factor annually. That is the largest inflation item on our income statement. So if it's going to happen, we have to budget for it. So we are going to allow about an 8% increase in pharmaceuticals and drugs this year. There's lots of data out there. We have GPOs, we have good industry information that it's going to be about 7.8% this year. So that will be placed into the budget. Again, we are allowed to increase our charge master by 5%. So we'll be looking at how we charge for those drugs as well. But that is going to be the largest inflationary impact that we have in the budget. Purchase service and other expenses range anywhere from 1 to 3%. We We will be looking at a capital budget of about $40 million. That is for small construction projects, new equipment, replacement equipment, and all of our IT needs. So that is kind of an overview of the capital and the operating budgets this year.
Any questions for Sharon?
Sharon,
Yes, sir.
the tax rate, how far are we from the ceiling?
Far away from the ceiling?
Right.
I'm not sure I understand the question.
Our tax rate now for the district, the homeowners is what?
There wouldn't,
You don't have a ceiling, you said, what the commissioners.
yeah, we don't have a
That's
ceiling.
what the commissioners. Yeah.
So whatever they allow for is what our tax rate is going to be.
Oh, so we're governed by the overall county's taxes.
Yes, sir. Yes, sir.
Commissioners.
And
The
the commissioners will set that. They can increase it, decrease it, or maintain it. But there are no particular ceilings or floors.
A follow-up question to that, though, and my question, Sharon, is we've got 479 million cash reserves on hand right now. You're budgeting to be able to basically keep cash reserves at the budgeted level for next year's budget in terms of contributions. My question is, do we need to think about or take a look at fund balance as either a potential contribution to reduce operating increases, or B, a reserve as it relates to potential capital contributions for the bond campaign? And I don't think that's a question for the moment, but I do think to the extent that we've been fortunate and we've been able to continue increasing our fund balance, to the extent that we can either, contribute that toward cost or put some sort of a marker on it as opposed to contributions for the bond campaign, to me, that kind of makes sense, because we went through this 7 or 8 years ago when we had fund balance issues, and they were high, and we were having problems with people thinking that maybe we weren't putting all that into services. That does not need to be that loud. But if, as that continues to grow, we've done a great job in terms of meeting margin now for the past really couple of years.
Right. Right.
Is it worth a consideration, or at least a budget notation that might take into consideration those continuing to grow assets in light of what we know we're going to be some pretty expensive capital days ahead?
Trent, along those lines, we discussed that back in some finance previously about, is that fund balance built up? Could those dollars be used? And certainly that's the direction of the board.
There's two
The other-
things. I'm sorry, go
But
ahead.
the other issue being, where's the 115, where's the replacement of those dollars going to impact the budget when the waiver technically, expires December of next year? So.
Your point is well taken, because I think taxpayers are due consideration if they say, is JPS stockpiling money? And the challenge that JPS got into years ago is they were getting federal funds, they were taking those monies and banking them, but you couldn't really make a strong argument that they were expanding patient services. And so you sort of had an imbalance. I think your note in sort of the asterisk of what is it that we face? We have two issues that we face, and that is, one, does this county want to proceed with the bond election? And then secondly, what we do with what we know is a deadline on the 1115 waiver. Now, the 1115 waiver may well be expanded, continued, or a new program will be into place, but I do think we're at a pivotal point in time that we could make three arguments to the taxpayers that are valid. One, we have put monies back into the process of expansion of patient services and care, not in necessarily new programs, but programs where we were short in providing the services that we already had. And improving quality, very much. So I think we've got that argument, and then I think we have the two looming issues that are fair to say we are at least trying to think that, but I do think it could be a notation in the budget that we're very upfront with taxpayers, because one, we've got nothing to hide, and two, I think any smart planner in business or in your personal world would do the same thing.
I think the question that I think Ralph alluded to, there's not a cap, but obviously based upon the press and everything else, we know the valuations of the property has certainly apparently gone up. I mean, that's obvious. So the question is, where is that tax rate set? How does that affect overall dollars?
And I think the other question is, should the county reduce taxes? Should they change? How do we accommodate at what we do at JPS to deal with our budget? Because the county could say, we're doing better and we're going to provide some tax relief.
Correct.
And so I think we have to be prepared with what we do.
Now, to Reverend Emerson's question, though, there is a question of, don't we make a recommendation to Commissioners Court on a tax rate? And if it's above a certain amount, then there's a process. I mean, not that we would do that, but
Right.
if we could.
Right.
Did you make that?
Warren might make that motion.
I would make the motion we just adopted.
That would probably be a good
I
motion.
think politically,
You'll probably get a quick second on that.
We do that in August and September.
Right.
We present our budget to the Commissioners Court.
I have two other questions. One is, I want to look at the capital budget for a second. Is that 40 million a pot that will address small construction, equipment, and IT? Or do we have, of the 40 million, 10 is for IT and 5 is for, or is it just a pot?
Currently, the way that we look at it is it's just a fund of money. And then from a senior executive level, we go through and we look at what the needs are for the district. It typically gets spread across fairly evenly, but we don't go in and say it's a hard, 1/3, 1/3, 1/3. It's kind of evaluated every year to see what the needs are for that upcoming year over that 12 months.
Because I recognize that there are construction needs, that things we need to do. I guess my concern is that how we're looking at that long range as it applies to new construction on our entire plant. That's when I asked that.
Yes.
The other thing is, when we started talking about the bond program and the financial advisors were meeting with us, and they talked about the revenue that we could generate to cover the bond, that it was at 2% productivity area. Will we be able to see or address what that has done this year in the performance, this overall out of the hospital? And when we see the budget, will we be able to say, well, based on this, we generated a 2% reduction for cost savings?
We can look at that like in an overall cost per adjusted patient day,
Okay.
and look at an overall cost based on overall volumes, and bring you back an overall cost metric. It's very difficult as some of our volumes start to shift from inpatient back into outpatient.
Okay. The reason I ask that is because, and I'm not asking to bring that forward. I ask that because there was much discussion on that.
There is.
Okay. And I guess my question should have been, when we look at the numbers going into the bond, will we be looking at that again? Yeah. So, I just want to have that kind of clarified before we get deep in there.
Yes, we will. And then part of the planning process outside of the budget is more of a 5-year business plan that we are currently updating that 5-year business plan for current cost and revenue structures. The plan that you're referring to was done back a few years ago with kind of 13 and 14 data as the basis. And then we layered on assumptions. So what my team is doing right now is updating all of that data with 15 and potentially 16 cost and revenue data. And then we need to bring that forward as we're working through all of the new planning process that we're doing in connection with the Commissioner's Court and all the new RFPs that are going out with that and the studies. So as that process moves along, we'll be changing those business plans and those pro formas and updating those into a brand new 5-year business plan and what comes out of those RFPs and recommendations. So that will change significantly from what you've seen in the past.
Maybe, as things go along, we could call the mayor of Arlington and ask Warren to politic for us and get some of those $1 billion they're gonna do for Texas run the stadium. In our budget.
I got Jeff's cell number if you want it.
Right.
So does Warren.
I have
Yes, sir.
one more, and I think there's a third option, back on that cash reserve designation. And the third option would be, to the extent that we have identified an amount of cash fund balance over and above our fund balance requirements that could be used toward this 40 million to enhance that, to begin to improve some of those long-term capital projects where we haven't really been able to put in place a long-term maintenance fund. But maybe when we've got some of those assets that have exceeded depreciation, that maybe we get a chance to accelerate some of those replacement schedules and try to create some more capital, benefit for us, because we've always had the problem of these aging assets and trying to keep them going with bubble gum and baling wire.
Right.
If we have the opportunity, that would be another option that we might be able to take a look at as part of that reserve increment to help.
Yeah, good point.
If that becomes something that's a staff recommendation, I think I would like to see that as an option as we look at, final approval of the budget.
You bet. Okay. Thank you.
Okay, thank you.
All right.
So I'm gonna go ahead and, sorry, I just took your job. I'm gonna go ahead and move into the financial report if there's no other questions.
She's got the title, I mean,
Chuck,
I did have one question
Oh,
about
sorry.
psychiatry,
Yes,
since you broke that out.
Yes.
This week's newspaper, Texas Health Resources, was buying or getting or whatnot, a mental health, mental retardation
Yes,
facility.
yes, sir.
Richardson, I think.
right.
Will that be an inpatient facility?
It is.
Will that not bleed the paying patients to that? We would expect an increasing.
No,
Okay.
not at all. Not at all. It's the wrong side of the geography and wrong side of the region, and it won't have any impact.
Perfect, thank you.
But
It's Richardson.
it's,
Be happy with the handling of it.
yeah.
We've had a proliferation of inpatient beds, for-profit inpatient beds over the last 2 years. January of 15, I think there were 300 new beds come online.
Wow.
That has had absolutely zero effect on gas, and we're still sending patients to those facilities to care for those patients when we're at capacity. You'll see a recommendation today to increase that limit to a certain facility that's been helping us out before.
Saw that.
Yeah.
Do they try and transfer people from their inpatient facilities to ours, the unfunded?
Sure, they do, but we often don't have room to accommodate the facility.
Okay,
Good question.
thank you. Thank you.
We, on this side of the table, got kind of worried when you started talking about behavioral health.
We all
That
left.
both sides.
Everybody just lives up and leaves.
Did you all get the message?
Yeah,
I said, Ralph, you appointed.
What category you're in.
Ralph had a quick committee.
Make sure we made our point.
Back to the serious stuff. Sherry, go ahead.
Oh, that's fine. So for May, we had a strong financial month for the hospital. You can see that admissions were down by about 5%. We had patient days following down by about 3%. Our length of stay was down by just slightly by about 1%. And however, the case mix was up, the acuity of our patients, they were a little bit sicker, it was up by almost 5%. Our key outpatient stats that we look at, ED was up by 16% compared to budget. Total clinic visits at our community health was down by 1%. Urgent care was up by close to 4%. And the overall outpatient clinic visits were down by 1%. Some of our other key stats were observation days. They continued to be high compared to budget, up about 14%. Births were down by about 6%. Inpatient surgeries were up by 11%, and outpatient surgeries were up again this month by 23%. And from our psych area, psych patient days were down by about 7%, although they were up from April. The clinic visits were up by 28%. You can see that the emergency visits were up by 17%, and the partial hospitalization days continue to be high as well. Again, we were able to restructure those about a quarter ago, so we've been able to get more patients through. Our FTEs per adjusted patient day continues to be favorable. From a rev cycle standpoint, our days cash on hand is just under 300, and our net AR days is at 46 for the month of May. Our payer mix slide doesn't change much, but it's a nice picture of where our patients come from. Again, this pie chart shows charges, gross charge, and where the patient payer source is. So we're pretty equally split between Medicaid, Medicare, our connection, and self-pay. We do have about 12% commercial. Our JPS Connection Enrollment Program has indeed leveled off over the last quarter. We remain right at 42,000 enrollment members. And for the month of May, again, another very strong month for the hospital. We were able to have income from operations of just over $3 million compared to a budget of $1.3 million. Again, from a net patient service revenue, we were right on budget. We had a little low on inpatient revenue, as we saw in the first graph, but our outpatient revenues were strong, so those two offset each other. I would like to point out that our ad valorem tax revenue year to date, although our collections were a little slow at the beginning of the year, when you look at the year-to-date column, we have collected cash just about where we expected to be by the end of May. So those have right-sized. And in other operating revenue, you see that we are about $597,000 ahead of budget. Again, if you drop down to supplies, we are over budget in that category. That again is related to a drug grant that we have that passes through some of these high-cost hepatitis C drugs. And I will be talking about that for the remainder of this year. That is a new program of drugs that is going through that grant income as well as the supply expense. So we'll continue to have that variance each month. Our salaries and benefits are right on track for the month. They're $164,000 under budget. And our purchase service is under budget, $2.4 million. Most of this is due to some physician contracts. A lot of our physician contracts we have realized were budgeted kind of at the full capacity, the full payout, and not all of those will reach their full payout. So we're going to have some budget underages for that. Another large piece of that is as we closed out PG this month, there were some overaccruals in PG. We try to estimate what some of that physician activity is, and then as we closed out those contracts, we got a credit back. And so that created a slight pickup. There were also some delays in other contracts, a lot of IT, as well as some other purchase services that are creating some savings there. Again, in supplies, we had the grant drug expenses that came through, and we also had some high infusion medical supplies. Those were some high-cost drugs that get expensed. So overall, again, a very strong month. And does anybody have any questions about the month of May?
Yes, sir.
Yes.
When and where will we realize the PG cash balance contribution back into the network?
From an income statement standpoint, that will not show. I can show you where the cash was transferred already. That happened, if you recall, I believe it was back in May when we approved the dissolution here. The board approved it, I believe. It was in an earlier month, but the cash has already been transferred back into the district.
That was in March.
Did that become did that, on our income statement, did that show up as a other revenue, or how did we classify it?
It would not be on the income statement at all. It was just a balance sheet transfer.
Okay.
So
it'd be reflected in the asset sheet.
it is in the balance sheet.
Okay.
So if you look at the balance sheet here, the PG cash is at just under $1 million.
Okay.
And the cash has already been transferred over to the district.
Okay, perfect, thank you. And
Yes, sir.
second question, and Bill, and I apologize for not being at quality, you guys can answer this question. Relative to emergency department visits continuing to grow and OBS, where are we on boarding times? Do we know?
Yeah, we do.
And
Bill, before you answer that, let me get this mic so everybody can hear you.
You know, we changed the way we measure boarding times, and instead of calculating boarding hours, and you know, at one time it was 10,000, 11,000, 12,000 a month. We changed it on a boarding time per patient before they're admitted to the hospital. So our target was 2, and we've been running about 2.8.
Okay,
So it's a little bit above target.
okay. So
Still have
volume
issues, still have issues every day in regard to that, but the throughput, the workflow, since sound has been on board, has improved dramatically.
Okay.
I mean, they have a plan each and every time that we get into that situation, and they work that plan daily.
Okay, thank you.
So one page that I typically do not cover, I believe it's page 12 of 17 on your portal. is the combined income statement, and I did want to point out, this PG column. This kind of lines up what we just covered with the hospital income statement. PG, which I have not shown any other detail this month to you in your packet. A claim, which I will be going over here shortly. And the foundation, which is always here, kind of as a FYI for you. And this column is just a simple summation of the other four. As you are aware, we kind of have wrapped up the activity, the ongoing activity in PG. And we did have about 2 to 4 days worth of salaries that were going through PG. So you can see that we had about $278,000 of expense that did hit in May. We are working to clear out all of the assets. You see some depreciation that hit in May. And then as we clear up the balance sheet for the next 6 to 9, 12 months, we're still billing out of PG, we're still collecting. There's some prepaid activity, some insurance activity. You will see some smaller things coming through that income statement. But that is just there for reference. If you have any questions for me on that, I'll be happy to answer those. But you'll just see very little activity. If there is anything large that comes through there, I will be pointing that out to you on a monthly basis. But as of May 1, a claim has taken over the actual clinic activities that were occurring in PG. So I will be moving along to present the acclaim income statement to you. And that is going to be on page 15 of 17 in your packet. So really on a claim, what you see here is what you approved back in January and February for the new acclaim budget. It began activity May 1, and there are two major variances that are occurring here that you can see. One is in net patient service revenue, and the other is in purchase service. And that is because we are still working with our partners at UNT to onboard the contracted physicians for UNT. We have employed the acclaim physicians that were in PG. So you see salary expense, we are billing and recognizing patient service revenue for the physicians that were in PG. They are now in acclaim. And income from operations from that activity, a loss of 405 compared to a budgeted loss of 523. So we are within our plan, but just so you understand, those two major variances are because of that delay in the contract. So when you look at the key statistics that we'll be covering, the one adjustment that I've made on this page is that we have removed the encounters and from these graphs so that you're just looking at the employed physicians so that you can see what were the employed physicians supposed to be producing to what did they actually produce. So these graphs should be meaningful and relevant for the physicians that we are looking at today.
Could you repeat that? I got lost.
Okay. So for the acclaim, on the graphs or or both or all of it?
Just on a claim.
Okay. So for a claim, the plan for May 1, when we approved the budget a few months ago, was two things. the PG physicians, the employed PG physicians would be transferred to be employed by a claim, and that happened on May 1. The second thing was that the contracted physicians that were contracted with the medical center would become contracted with a claim on May 1. And all of that activity would be flowing through a claim on May 1. That has been delayed by a few months, and we're still working through that contract
The contract
with UNT and a
yeah,
claim.
okay.
Those physicians, that activity is still, we're still under contract, but that contract is still reflected in the medical center. So a claim is not able to financially show that activity because that contract is not yet, it's still under negotiation. So until we get that signed, we're just not going to have all of the patient revenue shown on this income statement or the purchase service expense. So it's kind of a wash on the bottom line.
Right, gotcha, thank you.
So the encounters are slightly under, they're about 9%, and the encounter per day is also under as we start to ramp a claim up. But the net operating expense per encounter is favorable. So, and then you can see in the bottom left, the monthly encounters by department, family practice, internal medicine, oncology, and pediatrics.
Okay, so I understand that we're taking some time to move some things around, and so it's creating what looks like an income slump. Is that gonna be made up at some point, or do we have recognized lower expenses as well? I mean, when does that come out of the wash? When do we even out?
It's actually, you're right, the income itself is low, but our expenses are even lower. So we're actually coming out a bit ahead for the month of where we had planned to be. So the activity is still within the system itself. The contract is still just residing on the hospital side.
But there's still work being done.
There is still work being done. The
Right.
patients are still being seen. It's just not showing on the acclaim financial statement.
So where is it showing up?
UNT providers, under their old contract with the medical center, still bill the patients themselves. The bill is not shown on,
So
through
it's
this
kind of
acclaim.
bypassing the JPS.
It is,
Okay.
I believe, yes. So, from the acclaim standpoint, we're not, you use the word income slump. It is lower up here, but realize that we've also got an offsetting expense.
Expense slump too.
Yes, an expense slump too, yes.
Corresponding.
I'm
So-
very good at this accounting terms.
Okay, it's fine, just as long as you get them both in there.
Right.
So we did meet the acclaim budget this month was an important point that I wanted to make, even though we did have that contract delay.
So when do we expect for that to, are we suffering any real damage for that, or is this something that we can go on forever because it doesn't really hurt us any?
We wouldn't
Medications
we
take
wouldn't
place.
get along with it forever, and we don't need to be forever, and we're not getting hurt by it. It's just a matter of trying to, the University of North Texas Health Science Center originally was going to basically have a lease agreement with us. That seems to be potentially, the discussion is whether that has changed and they become just employees of a claim and how we go about doing that. So it's a matter of the proper transition.
Right.
The other issue that we face, that we want to be fair, is if you come into a claim and you are about to retire, it's, I think, quite unfair for those physicians to lose their state retirement benefits just because a decision has been made within two boards. So we want to be accommodating to those that are about to retire as well. So that's a consideration. So trying to find out those numbers and make sure that we get that right. But nobody's losing at this time and there is no harm. This is basically a continuation of status quo.
Right.
We just want to transfer them into a claim the best way possible for them and for us.
Yeah. I don't know if this is the right time to ask it or not, but I know that there were some expenses that we've had with a claim or the major modification of what a claim start between what it started at and what it wound up, and North Texas was supposed to pay half of those, right? Did we ever see that money?
That has been paid.
Yes.
There was actually a settlement agreement drafted and has been signed by North Texas and by the Tarrant County Hospital District, and all of those, that 50% of that has been paid and documented.
Does that show up somewhere?
The monies that transaction was on the balance sheet of the hospital.
Okay.
So those expenses that were billed to UNT were never really on the income statement shown as an expense on the district income statement. So it was just a payable and a
We had real
receivable that
expenses
we
that
were
were
showing.
paid, right?
We did, we had cash out.
Right.
But you're not gonna see on the income statement, you wouldn't see a credit of that cash back because we had kept it over on the balance sheet and billed them for that,
I see.
their portion.
Okay,
But that has been paid.
thank you.
Charlie, you had a question?
No, I think Robert fully explained. I leaned up to, on Warren's question, that and I chair the Acclaim Exec Committee, and Ralph serves on that committee, and I serve there about through the bylaws, but there's been a tremendous amount of work. I just take this opportunity to thank really the hospital staff. May 1 was the target date. There was a lot of work to get to where they had to get to. I think our last meeting was 8 o'clock this past. We meet early a lot at the hospital. But I want to commend the staff, and Sharon serves on that committee, and Robert and Bill serves. Yeah, Bill serves on that committee, and of course, they have independent counsel. I mean, it's a complete separate entity, and that's the way it was set up to be. I think there is a little cleanup here as to whether we lease, whether we bring them in. The good thing is, it's not stagnant. There's ongoing discussion and negotiation. So hopefully in the next 60, 90 days, and hopefully even around budget time, we can have all that worked out. But there's been a tremendous lot of work. Ralph, you may agree or disagree, but there's been a lot of work in Acclaim to get that May 1 date was a target date, and I commend the staff on getting there. And also commend the physicians for their encouragement and their involvement with the process. I mean, we said all along, it's a two-way street, and it seems to be coming together and working. I'll leave it at that. So, thank you, Sharon.
Okay, that concludes my financial report. Unless anybody has any questions.
You wanna bring Kelly up?
Yes, on the,
We need entertain a motion to accept
Move to
Sharon's
approve.
report. We have a motion by Mr. Powell, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. So item 5B.
next on my agenda is the approval for a, contract with Aetna. But before we do that, I'm gonna ask Kelly Shelton to join me. I'm gonna take a moment. Last month, I was able to introduce 4 of my staff to you. And, Kelly was absent, and since she is here today, I would, like to be able to recognize her in a similar fashion.
She had sort of a poor excuse
Yeah,
for not
why were
being
you,
here.
why were you absent? What was the problem?
I was in a leadership meeting that I could not get out of.
Well, Robert confused your very recent wedding with the leadership, so
Yeah.
he was gonna blame your husband.
That seems to be a pretty good excuse to use for a lot
I
of
think it's a
things.
good one.
You just did get married.
I did.
Yes.
Exactly. Congratulations.
Thank you.
Kelly started with us in October of last year, so she was one of my first hires here. And I have to say, she has been a great fit for JPS. Kelly is a department of 1 currently. It is me and Kelly against the world some days with managed care. And managed care is a very fickle environment. It's very specific to your county, right? Managed care does not translate well from Lubbock to DFW to Houston. So I was very lucky to find Kelly through a mutual contact. She is the director of managed care. She is currently trying to fill 3 staff positions. So she will have a contracting position for the professional side with Acclaim. We have had a lot of fun with the Acclaim contracts this last 6 or 8 months. We've also had some great successes with some of the medical center contracts. She'll be hiring a contractor to deal with that side of our business as well. And we will also be bringing in an analyst to help us look at some of the data that is required as we walk into some of those negotiations. She has graduated from Dallas Baptist University with a degree in Human Services. Kelly has 20 years of experience in the managed care industry and has a unique perspective from both provider and the payer industry. I hired her away from United Healthcare in Dallas, but she has worked for TRICARE, Humana, Aetna, as well as Parkland. So, and again, Kelly is married and she has a 7-year-old daughter. But I do want Kelly, before we talk about the Aetna contract before you today, to tell you a little bit about some of the goals that she has for managed care in the upcoming year.
So just as Sharon said, our biggest goal right now is to fill those positions. We're looking for some managed care experienced contract negotiators. We are going to look for a hospital contractor, a physician contractor, and then again, an analyst. So that's our main goal right now. We are, since the completion of the initial phase of the physician Acclaim contracts, aligning those with the hospital contracts, as well as completing the marketplace contracts for the hospital, we are now reorganizing the department's processes. We are reevaluating and looking at our current contracts. We're doing some data analysis to see kind of where we are and what we need to do for the future. And we are also researching for those contracts that we don't currently have here at the hospital. So we're looking at all of the new commercial Medicare, Medicaid, TRICARE, and behavioral health contracts to see what would be a good fit for JPS at this time. And then there are going to be some new marketplace plans as well for 2017 that will be introduced, so we're looking into those as well. One of our other goals, it's a soft goal, I consider it a soft goal, is to develop the relationships within JPS to find out how the managed care department can better serve our internal partners. So that's where we're headed for the future.
I will say that Kelly's arrival and Sharon's arrival is incredibly timely, because in a world that was sort of pre-Affordable Health Care Act, we dealt with connection patients. And now in the managed care world that JPS finds itself in, she and Sharon both and the team over in finance are huge assets. And when you negotiate contracts with managed care, no disrespect to either side, but you usually do it in a room without windows and everybody's pulling their hair out at various times. So she's done an incredibly great job and an asset at the right time, right place. So accolades to both of those women that are up there. They've done a lot to move us forward in managed care. Gina and her team, the rest of them, our whole finance team, it's kind of been a real strong effort to deal with managed care.
And Kelly comes at a great time. I'm going to say what I just said. Kelly came on board and we've had to discuss all these managed care contracts through Acclaim too. Kelly came on at a perfect time to be involved initially through all that too. So it's great having one person carry that whole thing through, along with the experience she brings with her. So you say you were glad to find her. I think we were all glad to have found her. So
Thank you.
That's great. So we have in front of you today, we're requesting approval for a third exchange plan on Aetna. The effective date for this could be, Medicare Advantage product with Aetna. It would be September 1st. We would actually be on their website and as early as September 1. We have been working with Medicare Advantage with Aetna for quite some time now. There has been, we were hoping to get this product to you a little bit earlier in the year, but just because of some of the language in the plans, it has been delayed. But we finally agreed on rates as well as the language. So we would like approval on the Medicare Advantage product with Aetna Health.
Questions for Sharon or Kelly?
Motion to approve.
Motion by Mr. Petty, second by Reverend Emerson. All in favor, please say aye. Aye. Opposed? Motion passes.
Sorry.
Thank you, ladies.
Okay.
Thank you.
That was my last
Thank
one.
you, Kelly.
Thank you.
You probably feel bad they didn't have any questions for you.
I'm sorry.
You probably feel bad they didn't have any
No,
questions.
I am. I'm really sad about that.
Leave the mic now.
Mr. Whitman.
Good morning.
Good morning.
I'm not sure why I brought this up here because I can't see it. I don't have glasses, and I apologize. So hopefully my memory will, oh, I'm sure. Let's test it, all right? Let's just test it. The first request that you have before you is an amendment to the Texas Healthcare contract to add 1/10 of an FTE to Dr. Tessier's contract. And it's an amount of $28,569, as I recall. Dr. Tessier is an infectious disease physician, joined us last year and a half ago, and is responsible for antimicrobial stewardship, which is code for antibiotic utilization. Becoming a big deal. You heard Sharon talk about the increases in pharmaceutical cost. Antibiotics is one of those components. And Joint Commission is going to be really looking at this in the future. They're going to ask all hospitals to really develop a program of antimicrobial stewardship. So I'd request your
Charlie,
consideration.
That's germs.
Yes, I'm
Motion to approve. Second.
Motion by Mr. Petty, second by Mr. Powell.
After being harassed, I second you.
We Longhorns have to explain things to each other, so. We have a motion and a second. Any questions for Bill on this? All in favor, please say aye. Aye. Opposed? Motion passes.
Okay, the next request is to increase or authorize us to pay more than the $200,000 threshold, potentially, for patients that we refer from our psychiatric emergency center to this facility. I think they call it Oceans Behavioral Health Hospital in Fort Worth. It's one of about 4 or 5 facilities that we transfer patients to routinely. We're almost approaching 200,000. I think we're 170 some odd thousand through the end of May, and anticipate that before the end of the fiscal year, we would surpass that number and want to get ahead of this curve versus coming back to you and ask for forgiveness for doing that.
Heard the explanation. Any questions for William? Motion by Reverend Emerson. Second by Dr. Weber. Any questions? All in favor say aye. Opposed?
Thank you all.
Thank you.
We even did that without glasses. Way to go.
Yeah.
As if that Bill did good with it.
Good morning.
Good morning. I have 2 items before you today. The first is a contract for professional services. It's a second amendment for allergy immunology services for Dr. Susan Bailey. I think last month I brought her partner, Dr. Rogers' contract before you. She provides backup when Dr. Rogers is traveling or out of town, and so we would request approval of that coverage for Dr. Bailey.
So we're going to do item E first, right?
You got to do them separately.
We'll
Got to do them separately.
Yeah,
That's
so
correct.
item E, so we'll consider item E, entertain any questions for Diana? Entertain a motion?
So moved.
Motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes, and then we'll do the same for item E, right? It's just the second part of the same.
It is the administrative, it's the assignment of this contract to a claim on behalf of the Tarrant County Hospital
Exactly.
District.
Like we did Dr. Rogers.
That is correct, just
We
like we did
wanted
Dr.
to do
Rogers.
the same thing, a claim accept that, so I would
Yeah.
certainly make that motion.
Motion by Mr. Powell, second by Reverend Emerson. All in favor, please say aye. Opposed? Motion passes. Thank you, Diane. Madura.
Now, this is Bandera's first time
All right.
for finance.
All
I'm just
right.
saying.
Good morning.
Morning.
We have a little hazing process.
I think she can handle it.
I got here on time and heard the whole thing.
Well, welcome.
Thank you. Well, thank you for the opportunity to present the Immortal Fluency Direct proposal. And like Mr. Orley mentioned, my name is Madhura Chandak. I'm the Executive Director of Clinical Integration at HIM. And my primary responsibility is clinical documentation and effectiveness of coding. So what Fluency Direct offers here is it enables our clinicians to verbally create, edit, and sign their clinical notes in Epic. It offers that platform which is very seamless. And the top 3 successes with this, the first one absolutely being real-time availability of clinical documentation, which enhances patient safety, also helps with coordination of care across entities for us. The second one being it's really a big satisfier for our physicians because they want the ability to be able to document on their patient's chart from anywhere, anytime, really in the middle of the night if they wanted to, and be done with their charts in a timely manner. And the third one, for me, it's I perceive this to be appropriateness and high-quality clinical documentation as the true currency. In terms of the high-quality documentation allows for better coding, which then leads to better billing and reimbursement. So I actually have a list of 47 ambulatory providers that are waiting to get Fluency Direct services. We ran a pilot last year with 25 providers and have really good review from them or feedback from them. Some of them asked about Dragon. It's a comparable product. This is definitely way cheaper than what Dragon offers. So that's why the proposal.
Is it better than Siri on my Apple phone? Great.
Some of the questions you don't actually have to answer.
Lower rate yourself.
Thank you very much for the explanation. Any questions? Okay, we'll entertain a motion for this item. Motion by Dr. Weber.
Second.
Second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you very much.
Thank you so much.
Dr. Fowler.
Okay.
Good morning.
Good morning.
I have before you the renewal for UpToDate. And UpToDate is a tool that we use not only for learning, but it's for decision support for patient care. And the increase is about 3% annually. And UpToDate is used by all of the providers, the clinical care providers, and not only with the learning, but also with patient care. It supports best practice, it maintains up-to-date practice, and it allows the providers to have quick decision-making. The budget, it's budgeted, the previous cost was $137,404, and the increase is $4,216.
Okay. Here's the explanation. Any questions for Dr. Fowler? Entertain a motion.
So moved. Second.
Motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Dr. Fowler. I believe that Deb Saunders is going to come up for the next couple.
Okay. Great, come on up.
You're wrong. You have the right, I guess that's.
Yeah. Go ahead, since this is also your first time, go ahead and introduce yourself to the committee.
Good morning, my name's Jeff Woods. I started out at Peter Smith right out of tech school back in '78. And I left, I went to, traveled around, went to All Saints for a little bit. When it was still All Saints, I went to Missouri and worked in a neuro ICU, CV ICU, in a Class 1 surgery, surgery there. I actually worked for a couple of physicians here locally as a RNFA, Dr. Hubbard and Dr. Shank and some of the other physicians locally, and did some hearts as well. Came back, I got my nursing degree at TCU. I was director at Baylor All Saints for about 9.5 years and got my MBA HCM while I was doing that job. And I decided that I'd like to come home.
Welcome.
Welcome home.
Yeah,
welcome
just
here.
move that mic over a little
Yes,
bit.
sir.
There you go. Thanks, Jeff.
Thank you.
Thank you for being here.
Thank you. So can I move forward?
You bet.
Yes, sir, please do.
We are proposing the replacement of the striker integration and lights in the operating room at a cost of $1,733.66.99. Originally, that was quoted for $1.2 million, was submitted for the capital request.
Are you going over item J, or are you going over item I?
Oh, I'm sorry.
We need to do I first. So-
I first, okay,
Yes.
yes, sir.
Just the implant contract.
Yeah, the Cynthia's Depew contract, would like to seek approval for that. It was budgeted cost of $700,000, previous cost was $669,162, and it's an actual savings of $113,758 over 3 years, or an actualized saving of $341,274. So we're looking for cost savings opportunity in the operating room, and this contract represents one of those opportunities for cost savings.
Great. Heard Jeff's explanation. Any questions on this item? Entertain a motion for approval. Motion by Dr. Weber.
Second.
Second by Mr. Powell. All in favor, please say aye.
Aye.
Opposed? Motion passes. All right, let's do J now.
Thank you. We're proposing the replacement of the striker integration and lighting in the operating room, and it's at a cost of $1,733,066.99. It was originally put in the capital for $1.2 million, was submitted in capital request, and the remaining $533,066.99 was requested as an operations expense. After further review, the entire amount should have been placed as a capital expense in the capital budget, and we are now requesting the remaining $533,066.99 to be allocated from the 2016 capital contingency to make up that difference.
Okay, you've heard Jeff's explanation. Any questions? Celia? Entertain a motion.
So moved.
Motion by Dr. Weber.
Second.
Second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you very much, Jeff.
Yes, sir, thank you.
Okay, Jamie. Good morning, gentlemen.
Good morning. I'm Jamie Pillai, and with me I have Arthur Elgin. He's our Executive Director of Facilities Management and Plant Operations.
Welcome, Arthur.
So you may recall that we shared with you last year in July that our fire alarm system is becoming obsolete. As a result, the Board of Managers approved our request to upgrade the fire alarm panels for the main campus. The request before you is to start upgrading the voice evacuation system, the devices associated to the panels, and the information management system. We ask that you consider approving this purchase and installation agreement between the Tarrant County Hospital District and Simplex Grinnell.
Okay, any questions for Jamie or Arthur?
The same question I had, I think last time we talked about something like this. We're talking about building another whole facility in a couple of years. Is there some pressing need that says we have to fix this now?
Well, if it were another system, I mean, and not a life safety system, I'd say let's delay it as long as we could. But, you know, with being a fire alarm system and making sure that we can meet all our regulatory requirements, first of all, but make sure we can assure our patients and visitors and staff in the facility that we have a viable fire alarm system, I think is just something that we cannot delay. I understand, and I always try to ensure that we are good stewards of our dollars, but this is a life safety system, so.
Well, I understand that, but, I mean, that doesn't answer my question respectfully. I'm looking for an answer, you know, what says I need to replace the system?
Do you mind if I give you an example?
Absolutely.
Okay, so.
But give me a real example that's actually from the system. I don't need an analogy. I mean,
Okay, I understand.
I don't
So-
replace my ladders because it gets old, right?
Right.
But a ladder's a pretty safe, big
Right,
deal.
but you replace your computer if it got old, right?
I replace my computer when I get the blue screen of death too often.
Right. So that's kind of, okay, and that's a great point. That's kind of where we are with our fire alarm system. So we're at a point now where the software is becoming obsolete. The devices are no longer supported by the vendor that we work with on a daily basis. So in order to ensure that our system is viable, we have to, I mean, it's a computerized system.
Sure.
So just like other computerized systems, we have to upgrade that system from time to time, just to make sure it can be fully supported by the vendor.
I get that, and this is a new laptop here, I'm breaking it in now. I know whenever I see these huge proprietary systems, I know that the world is decentralizing, and I haven't done the work to say authoritatively that we could replace this with an open source deal that's not gonna be the same, or that wouldn't be the same cost, or that we couldn't pay for it out of operating cash as we go along. But I strongly suspect that it's there.
Well, if our basic system, if many years ago, when we decided to, and this is something that completely predates me, but many years ago when BACnet and LungWorks and other open protocol systems became available, if JPS as an organization had decided to take that route and go in more of an open protocol type system, then yes, today we would be able to look at some of those systems and say, hey, you know, we don't have to go with a proprietary simplex, we can go with Johnson, we can go with Honeywell. However, we did not take that direction, and now we are basically in a situation where we have to deal with them because the opportunity to convert that to an open system at this point would be very expensive, and that I don't think would be a good use of our funds with the potential of maybe moving out of that facility in the near future.
But just like 6 months ago when we talked about this, and I asked the question, there are some of these systems that are so much cheaper that a provider might come in and say, for the amount of money that you are paying just to upkeep, just to maintain your current system, we can replace your system over time. Right? I mean, am I wrong, or am I out of left field on that?
Well, I mean, it's possible, but I think in order to, I mean, just sheer number of devices that we have in our system, and they are proprietary devices, we would have to go into an existing facility and try to take out one fire alarm system and replace it with another. Cost comparisons to what we're doing as far as upgrades, I think it would still, even with a lesser expensive system, I think it would still be very expensive.
Yeah, but the direction we're going here is we're never gonna get out of it. We're gonna be doing this every year or two until the end.
Well, hopefully the end is in sight, but we still have to make sure, I mean, granted, we have some systems that we are making a decision to say, hey, we are, hopefully we're gonna be out of this building at some point in the near future. We're just not gonna upgrade that. But the fire alarm system is just not that system. I mean, I need to be comfortable, and I need to ensure the network that we have a system that can be supported by our vendor. And when we got outdated devices, we've got outdated software, I just can't give that assurance.
Okay.
Sheila, you had a
Yeah,
question?
To Mr. Norwood's point, one of the other things about our institution is that there are places in the hospital where if you wanted to wire something new in, you're not really sure, they'd have no idea what they were bidding on, because there's no blueprints, there's no nothing for large pieces of our hospital. We don't know what's in the walls. And then you start tearing the walls out, you don't know what you're getting into.
Wow, I didn't know that was there, yeah.
Yeah, the $250,000 beam in my labor delivery unit was.
New systems are all wireless, we don't deal with that
that's a 10-year ago problem.
Reverend Emerson, you got a question?
Yeah, I want to go back to Warren's question of if, could we wait? If I thought what I heard you ask, could we wait and get?
That's really, that's a secondary issue. The first issue is we're blindly going down this, we're locked in these guys, we're chained to the proprietary people, and we're never ever gonna even look. We're not gonna bring in somebody else who could say, I can, for the amount of money, I think last time we looked at the fire, it was like $50,000 to $100,000 a year we spend just normal maintenance of this system, right? Something like that. It may be that there's somebody's out there that say, I'll just replace everything you've got for $100,000 a year or $200,000 for the next 2 or 3 years. And when you move, I'll take over from there too. We don't know because we haven't looked. We just don't know. So we're going to vote to continue to remain chained to these guys forever, or until such time as we tear down our buildings and move to a new building. Everything is wireless these days. You don't have to worry about things being on the wall. Yeah, it just isn't that hard to at least look at what we're doing.
Okay. Well, I guess what my concern is I thought in the last report that we had, and I remember you raising that question, but when we raised that question at that time, I think we also talked about it was a position of cost at that time. Had we removed and changed, it was going to be greater to do that than where we are at this point.
No, last time we looked at it, the answer is we don't know because we haven't looked at it. We just assume that it's going to be more.
No. I thought the staff report said that it was going to be more.
Yeah, there's an assumption there. There was no report. There was nobody. They didn't go out for bid. I mean, specifically, I remember talking about it, and he said it cost money and time to go out and get bids on it, and it would. That takes time. It may be that we could call up the top 5 providers in the area, and they might say, "Oh yeah, you're right." I'd like to know that. I'd like to know that we talked to 5 people. We spent 30 minutes talking to a few people, and they said, "Oh yeah, we don't want any part of that." But we haven't made the 30 minutes of phone calls, from what I can tell. Am I wrong?
It's a good point, and we can most certainly look at that. We can most certainly look at that. But from my experience, from these systems, I mean, these systems are very, very costly. We've got to get NICET certified technicians to do the installations. I mean, an upgrade to the entire fire alarm system in that building would be very costly. But I'll be glad to do some research and get some information to you.
Well, we all want to have a new facility at some point. It'd be nice to have some history working with some people that would take us a different direction when we get there.
I agree.
So we need to have this conversation with these kinds of people anyway. If nothing else, just to establish a relationship.
Okay.
How much time does this buy us if we do this upgrade? What's the lifespan of the upgrade?
Well, there, of course, and this is a part of a whole. This is most certainly not the entire upgrade. The systems that we're upgrading now, the portions of the building that we're upgrading now, we wouldn't have to revisit for at least 5 to 7 years, at least 5 to 7 years. So, however, as I'm looking at things on a daily basis, trying to make sure that our facility is whole and that we can provide that safe environment, and I prioritize things, this one's just at the top of my list. So I don't disagree that there may be some more research that can be done. Me and my team will be glad to do some more research and get information out to you.
Well, you know what, we've had this conversation twice now, so you know what I'm gonna hit you with next time, right?
Well, hopefully there will be a next time. I will have provided you with enough information so that we can move this process along if that's the direction that we're going in. But we will do some research and be glad to provide that.
Thank you.
But I think it's going to surprise you. But I will get with my team and we will provide some additional research.
If I could, I certainly understand Warren's desire to know efficiency versus cost and longevity. Are we gonna tear it out, not use it? I guess, as a member of this board, I'm having a hard time. We did discuss this some months ago, and I'm looking at you as our staff and the job you do. I keep hearing this word, the system we have in the facilities may be inadequate as a fire alarm system. I guess my question is, I don't want to just leave here today and say, well, maybe we get this resolved in 90 days, and God forbid we have something happen within the facility, and we don't think we had the right system, or we didn't have an adequate system. I guess my question is, if we're going to where you do a little bit additional research out there, the question is the system we've got today, are we running at risk that system is not adequate enough to do the job that this board and this district and the people who empower us to make decisions? Are we protecting? You keep talking about the healthcare issue here. That's what we're here about. I certainly agree with the cost factor. But what's the cost factor if the system, we have a problem during this time and we didn't upgrade the system? What's the cost of that? So again, I don't have any problem if, Mr. Chairman, if that's where we're going to possibly do a quick analogy of some comparisons, but I just want to make sure we don't leave to the public and to ourselves that we may have an issue within the hospital with our fire alarm systems, and we didn't act upon it to get it corrected. That's the only point I want to make. So I'm fine with looking at comparisons of dollars. And maybe that should have been done more, and I don't disagree. And if we can get that done in a short period of time, and we don't run the risk of exposing our patients or our employees or visitors or whatever, then I'm fine with that.
I am trying my best to recall that whole conversation in the past, but I thought one of the issues prior is where we are with what we have. We need to go the route we went, and the other route would have been gutting the entire system.
That's exactly right. And that's basically what he's saying. I mean, from some preliminary numbers that we've been given, and we can do more research, but some preliminary information that we've been given, it would be approximately $4 million to replace the existing fire alarm system in that building because of just the sheer nature of the logistics of changing out one device for another in an active operating hospital.
Where do you get that number?
We got that number from some, Snyder Electric did some preliminary investigations for us. We were looking at doing an audit project a couple of years ago, and we got that information from a vendor other than Simplex.
So that was Snyder saying we can come in and we can change everything from some Simplex to
an open protocol, more of an open protocol system. That'll allow us to use multiple vendors if we needed to do upgrades or any type of modifications to the system.
Other than the issue of the proprietary system that we've got.
The issue is a proprietary system.
That's what we're faced with. It's not
that's what we have. I mean, that's the system that we have.
We just don't have three comparisons of three systems to look at, open system versus the proprietary system. And I think everybody would probably agree. I know it's open, but there's still cost in an operating facility. Usually your costs are greater when you're converting over, dealing with, in my experience with buildings and things, it's more costly sometimes when you're in an operating versus when we build new facilities, hopefully a new campus, and obviously it'd be cheaper.
Certainly, it's more expensive to put a roof on a building when it's being used than to just build another entire building with a roof on it.
Well, unless you get a roofing company, it makes you a good deal. I don't know, Warren, but I think our staff has done adequate to get to here. I think philosophically, we're kind of, do we wait and
but
see?
I think one thing that will help I appreciate your questions, and I think they're good, and I think what staff has done is their due diligence. One of the things that might be helpful, depending on your time, is to dedicate an hour to us and walk through the process, because at JPS, to Dr. Massengill's point, we do have issues with the fire marshal on what we can have wireless and what we have to have hardwired through the system. It's not as easy as a home system, and with a system that has as much square footage as that, and it is a system by which, if you've ever gone through the hospital with a cell phone, you'll know that there are parts that you're just not going to have an ability to have a transaction. No matter how many antennas we put up, We got antennas on antennas. The way the walls are and what we have over there, some of it's hardwired.
Well,
So-
all of it's hardwired now, most of it's hardwired right now, right?
Right.
Right.
And
So those wires are there.
Yeah,
Yeah.
wires are
Right,
there.
and there are portions of the system that would have to remain because of certifications and requirements, regulatory requirements.
But the
have to
wires
remain
are already
on
there, it's not like you're having to.
No, you don't have to do that, but I think it might be helpful, depending on your time constraints, is to at least get the magnitude of that building and some of the archaic nature of that building, especially when you step back into the 1947 portion of it. It was overlaid with the 1960 and 1975 portion of it. It does get a little more challenging, so your points are well taken in sensitivity to the taxpayer, but between now and when we ever revisit, if we do, it would be helpful, I think, one, because of your interest, to look through that process with us and walk through it a little bit. And we won't take you, make you go through the attic or anything else, but I think it would be helpful
I
if
get my
you
hands
could,
dirty on a routine basis.
if you could see.
You are an engineer.
I think it'd be
I
helpful.
am an engineer.
You are an engineer.
This buys us 5 to 7 years, and it's 250,000. We're having this long discussion over 50,000, and I can't imagine we're gonna get a new system for less than that. So I'll entertain a motion one way or the other, to the pleasure of the board.
So moved.
So,
Motion for approval. Any further discussion? All in favor, please say aye.
Aye.
Opposed? So yay, and,
I voted aye.
okay, voted aye on the no, or aye on the aye?
Aye on the aye.
Okay.
Aye, aye.
on-
Yeah, aye, Captain.
Aye, aye.
There go.
Thank you, sir.
Thank you.
All right, thank you.
thank you.
Thank you, guys.
And I think there's a learning curve here too. I think anytime we look at things in today's world, again, staff does a great job. Y'all probably look at all this stuff, Father and Jamie. I think it's one of those things where probably an overkill when it comes to expenses is probably a good idea. I know, it's just
Oh,
personal
the
thought.
final parting
I think
thoughts is,
points made,
I think that we probably have an excellent system, and we've got an excellent system. We're buying and upgrading an excellent system. But I don't drive the most expensive car I can, and it's a safety system. I drive a good value vehicle, and people would probably say it's a little higher than I need.
Right.
I'm perfectly okay with that, but there are other options, and it's not good enough to me to wave our hands and say it's gonna be more expensive without any documentation. Show me what we did at Snyder.
I agree.
I've seen your Prius and I like it.
Yeah.
I think it's good.
Yeah.
I think it's a nice
Don't be
car.
saying that.
Yeah.
People think I've got one. This is Tarrant County.
The other side of Warren NORAD.
We'll finance you something else for it if you want it. I'll make you a
I
loan.
just want to I want to make this one
Kathleen.
comment before they leave. It's something that Dr. Maskell said. I was trying to get this in. Where there are no as-built, you really can't talk about converting. You really have to talk about replacement. And the reason I say that is because I just went through that experience when we just built our church. We had no as-built. And when we put the system in, the fire department came through. We couldn't convert. We had to replace the entire system. It ate our lunch.
Well, I think the other thing is, we're all sitting here, I hate to use the word in the political world, the big elephant in the room that we're not talking about, I'll say the big donkey in the room, whatever, but, we know the facilities need upgrading. We all are sitting here looking at each other knowing our facilities need upgrading. And yes, no one wants to waste dollars in the short run, but we want to get on to hopefully where we can get on with the new facility, and that's, we all agree on that. And
Kathleen, are you discussing fire alarms in any way?
I am.
Okay, then you can
Please.
proceed.
Yeah,
I
but
will-
Kathleen
no, no.
always saves money, so we.
Not today, though.
Well, not today.
Not
I
today.
saw this one, it makes me a little nervous.
My life just doesn't make sense anymore.
We're gonna have the
Go ahead,
previous.
Kathleen.
I'm here today to ask approval for a contract for Philips Healthcare for the purchase of 3 ultrasound units.
Kathleen, move that mic just over a little bit. There you
For
go.
approval for 3 ultrasound units from Philips Healthcare. 2 are for the cardiovascular program, and 1 is for the OR at the request of the anesthesiologist to have 3D capability for when they're doing open heart surgery. And that is why we're a little bit over budget, and
Just
the
an
remaining
upgraded one,
balance is
right.
coming through contingency. This contract did go through the RFP process, and we bundled the 3 units together. And it does all of them interface with the PACS system for image archiving and to the EMR.
Okay. Heard the explanation from Kathleen. Any questions for her? motion?
Recommend approval.
We have a motion for approval from Dr. Weber, a second from Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, Kathy.
Thank you.
Any items from legal?
No.
Nothing
Nothing in exec.
Nothing in exec, and
Can I make one announcement before y'all adjourn? Thank you, Mr. Chair, for your excitement. While I have y'all here, the chairman and I have discussed, we have two meetings that are predominantly at the same time. We have, is it July 14th and the 28th? The July 28th meeting is a joint finance board meeting. We can't move that. That's the time frame by which our staff is prepared to get you information and prepared to go. So the chair and I have discussed not having the July 14th meeting. And we would cancel the 14th meeting because you'd
All in
really
favor,
be
please say aye.
having
Oh,
two
sorry.
meetings back to back. So if we could do that, we'll just have the July 28th meeting. And now that I have y'all here, and I'll mention it at governance for anybody who's new, but I just wanted to say I appreciate the chair's attitude towards this. The chair of the entire
Oh, the-
board,
the real
not the
chair.
finance
Yeah.
chair.
Yeah, you didn't comment whether the chairs already agreed.
More than one chair.
So, if you have any questions, you can refer them to the chair of the full board.
are you done?
I am,
Okay.
thank you.
No further business. We are adjourned.
Okay.
Ouch.